Let's carry on with our SCA crash knowledge update. Let's look at the breast cancer. So in terms of genetic breast cancer referral, when do you start thinking about referring a patient for breast cancer screening on the basis of genetic concern? So when and how should I take a family history? Take a family history of breast cancer when a person has concerns about their family history of breast cancer, a person has breast symptoms. If it's clinically relevant, for example, in a woman over 35 years of age using oral contraceptive pill, in women being considered for long-term hormonal contraceptive therapy, means we ask you if you've got a family history or a previous history of breast cancer. A woman has had breast cancer in the past, then all hormonal contraceptives actually should not be used. In that kind of situation, you should be thinking of advising her to use a copper coil. If a woman has had breast cancer in the past, then of course use of hormonal HRT becomes a little bit tricky. You might need to seek. Obviously, you need to explain the risk. I think estrogen only hormonal contraceptives actually don't carry that increased risk of breast cancer. I think with estrogen only. And obviously you could the Mirena coil is, I think, is UK MEC 3 for previous breast cancer. So it's likely, very likely, you want to avoid the Mirena coil. So if the woman still has a uterus, it would be safe for you to give her estrogen only contrast, estrogen only HRT. But the issue now becomes, well, how do you protect her endometrium? So that's why sometimes you need to have a chat with a menopause specialist to get the best. Or you could obviously consider non-hormonal treatments of menopause, medications like SSRIs, SNRIs, and Clonidine can be very helpful. Document a family history, including the person and your first-degree relatives, so mother, father, daughter, son, sister, brother, those are first-degree or second-degree relatives, grandparents, grandchildren, aunt, uncle, niece, nephew, half sister, brother. Ask about all cancer diagnoses, including breast cancer, and document them. Any cancer, you need to ask about it. People in whom faulty genes such as BRCA1, BRCA2, or the P53 gene has been identified. That's of course an abnormal P53 gene has been identified. You need to ask about the age and diagnosis, presence of bilateral disease, obviously is a higher risk. Male breast cancer in the family is a higher risk. Multiple cases in the family, particularly on one side. So if you're having like breast cancer or cancer diagnosis in one particular area, like your father's line or your mother's line, then it's more likely that it's a genetic breast genetic cancer, inherited cancer gene. Jewish ancestry. A lot of times when it comes to ancestry, it's not really like there's something about the Jews that makes them more prone to breast cancer. It's more like most people marry within their communities, isn't it? So if there's a faulty gene, there's a likelihood that that faulty gene will keep being passed within that community. So it's not like those people are intricately or innately designed by nature to have abnormal genes. It's just that most people marry within their race. So if there is a particular abnormal gene, there's a likelihood that it will be passed within that race. Other related early onset tumors, such as ovarian, pancreatic, and prostate cancer, sarcoma, gliomas, and adrenal carcinoma. How do I assess a woman's risk of breast cancer need for referral? So of course, this is the nice CKS that we're reading from. People without a personal history of breast cancer can be managed in primary care. If they have only one first-degree relative or one second-degree relative diagnosed with breast cancer when over 40 years of age, provided that none of the following are present in the family history. There's no bilateral breast cancer, there's no male relative with breast cancer, no ovarian cancer, they're not Jewish ancestry, sarcoma in a relative younger than 45 years of age. glioma or children or childhood adrenal cortical carcinomas, complicated patterns of multiple cancers at a young age, two or more relatives with breast cancer on the father's side of the family. The father's side of the family. Offer referral to secondary care to people without a personal history of breast cancer who have any of the following. So the thing now is you're thinking about most times when you're thinking about genetic or referral for breast cancer screening on the basis of genetic, susceptibility, you're looking at this person hasn't had symptoms of breast cancer, or this person needs to be screened or needs to be considered for screening on certain basis, certain family history. So if there's one first-degree relative diagnosed with breast cancer under the age of 40, there's one first-degree male relative diagnosed with breast cancer at any age, there's one first-degree relative with bilateral breast cancer, where the first primary was diagnosed under the age of 50. There are two first-degree relatives, so a brother, sister, or two sisters. Because if there's a brother, it's already straight up refer screening, because breast cancer is about 100 times more common in women. So if a man has a breast cancer, then the family members should be screened actually for breast cancer, especially female family members. So what it means is that there's very likely a cancer gene in the family. If you have two first-degree relatives or one first-degree relative and one second-degree relative diagnosed with breast cancer at any age, so if you're having maybe two sisters with breast cancer, you're very high risk. If your mom and your sister, of course, two first-degree relatives, you're high risk. If maybe your sister, or, and a cousin, or a sister and a grandma, so one first-degree, one second-degree relative having breast cancer at any age, a diagnosis, you need to refer for genetic breast cancer screening. If you have one first-degree and one first-degree or second-degree relative diagnosed with breast cancer at any age, and one first-degree or second-degree diagnosed with ovarian cancer at any age, so one maybe mom has breast cancer, sister has, mom has breast cancer, niece, for instance, has, or stepbrother, stepsister has, because it's stepsister, if it's a stepsister from the mother, which means your mom marries someone else. If you have ovarian cancer, then you need to be referred. So three first-degree relatives or three second-degree relatives diagnosed with breast cancer at any age. Because that's screaming familial breast cancer. Imagine having three sisters, for instance, and three of them, or imagine two sisters and your mom, something like that, having breast cancer. Then what it tells you that you need to be screened for breast cancer. What if you're a man? Would you then need to be screened? And yeah, if you want to be screened, then obviously you would need to discuss the likelihood of him having a breast cancer. His risk will obviously be far much lower compared to if he was a woman. And then you have to explain to him what will be his issue. If he has screening that shows he has a genetic predisposition, what then would he want to do? Would he want a bilateral mastectomy? That's the question. Seek specialist advice from secondary care or a specialist genetics service if any of the following are present in the family history, in addition to breast cancers and relatives not fulfilling the above criteria. So obviously there's a family history of bilateral breast cancer, male breast cancer, ovarian cancer, Jewish ancestry. There's a family history of sarcoma in a relative younger than 45 years of age. You need to be speaking with specialists, you need to do genetics screening, breast cancer screening. There's a family history of glioma, childhood adrenal cortical carcinomas. So each time you see patients with a family history of cancer, it's really good to bring this up and look at the significant cancers that might need to trigger a referral for consideration of genetic screening. You have a complicated pattern of multiple cancers at a young age. Two or more relatives with breast cancer on the father's side of the family. If there's uncertainty about whether or not to refer, you probably need to be seeking advice from the genetic specialist, geneticist. If the person is not sufficiently reassured by the information you provided, you can always write a letter, advice, and guidance letter to the genetics service. So refer directly to a specialist genetic service if a high risk predisposing gene has been identified. So if this person has had a screening, BRCA1, BRCA2, or a mutated P53 gene has been identified, then to refer directly to specialist genetic service. What information should I provide? For all people, provide information on breast cancer risk, including information on family history, genetic risk factors. You have to give them patient information leaflets, links for them to read. Explain the principles of breast awareness. So this is a process where the person becomes familiar with their own breasts by looking and feeling and reporting promptly any changes, such as discomfort or pain, lumps, thickening, or bumpy areas, nipple changes or discharge, or changes in the appearance of the breast, such as in the shape or the presence of dimpling of the skin. The leaflets can be used by healthcare professionals to explain to women how to be aware of changes in their breasts. Give lifestyle advice regarding breast cancer risk, advice on reduction of intake, maintaining a healthy weight, increasing physical exercise, because obesity and being overweight markedly increases your risk of breast cancer. Same with cigarette smoking and alcohol excess. So drinking more than 14 units of alcohol a week also significantly increases your risk of breast cancer. You need to be advising on all of those things. Smoking cessation when appropriate. Advise women that the following may reduce the risk of breast cancer. So having a first child at a younger age and reduce your risk of breast cancer. Think even breastfeeding, breastfeeding also reduces your risk. Having a large family, which means you've obviously been pregnant many times. Yep. Provide details for sources of support and information. Give women appropriate information or contraceptives and hormone and HRT in terms of breast cancer risk. Provide information from the National Hereditary Cancer Helpline, Cancer Research UK, CancerNet UK. Provide other useful advice and information, for example, advise that they can bring a family member or friend with them for appointments. And for people who are being referred to secondary care or specialist genetic clinic, also provide information on the risk assessments exercise that will take place. Advise the person on how to obtain a comprehensive family history for potential outcomes, depending on the outcome of the risk assessment, including referral of primary care, management to secondary care. So essentially, what will the person thought about how they feel and what they want to do if they end up getting genetic screening that confirms they have a genetic predisposition to breast cancer. What do they want to be done? Would they want to pursue that further? How would they process that result if it happens to be that way? For people who are not being referred, also advise that they should come for review with their GP if there's a change in family history or if breast symptoms develop. Encourage attendance at the local NHS breast screening program for women aged 50 years. So if a woman is up to 50 years or she's 49, you've seen a patient who is 49, and you should be telling her that by the time she gets to 50, she will be invited to the NHS breast screening program. Obviously, she should be advising her to keep that appointment and get screened. The NHS breast screening program is a rolling scheme which invites women aged 50 to 70 in England, Northern Ireland, Wales, and Scotland, who are registered with a GP for mammograms every 3 years. Women at increase of breast cancer, for example, those with strong family history may be eligible for breast cancer before 50 years of age. So we just need to keep that in mind. Now, for women who are known carriers of a gene mutation, as if one has BRCA1 or BRCA2, obviously UK make 4, I think, for combined hormonal contraception, so you can't even use it. A copper IUD may be used without restrictions, category 1. The following methods are generally used. So you can use a POP, you can use a depot, you can use the next plan on implants, you can use a urine gesture and IUS. If the combined hormonal contraception has been considered, so it's UK MEC3, discuss with or refer the woman. So it's UK MEC3, not 4. She has these BRCA1 or BRCA2. Okay, so how should I manage a woman who has a family history of breast cancer who wishes to take hormone replacement therapy? If the woman is at low risk of breast cancer, that is, she does not fulfill the referral criteria to secondary care, home HRT may be prescribed. If the woman is at increased risk of breast cancer, that is, she fulfills the referral criteria to secondary care, ensure that she has been referred to secondary care for assessment of her own breast cancer risk. Inform her of the increase in breast cancer risk with type and duration of HRT, especially the combined HRT, estrogen only HRT. There's even a slightly reduced, it thought that it might actually slightly reduce the risk compared to the general population who are not on HRT. So estrogen only may be safe. It's thought that is a progesterone component of HRT actually increases the risk of breast cancer. Provide information on non-hormonal and non-pharmacological treatments such as antidepressants, SSRIs, SNRIs, both vaginal moisturizers, vaginal estrogen can be safely used, like the Vagfen, CBT, hypnosis, acupuncture, relaxation techniques could be used for medications like clonidine, isn't it? Clonidine can cause rebound hypertension and cause hypotension because it has blood pressure lowering effects, and then when you stop it, I think it should be stopped slowly to avoid, that rebound hypertension. So a lot of patients may not really want to go on clonidine; they prefer the SSRIs or SNRIs. Hormonal contraception can be considered in a woman with a breast cancer concern. For women with a family history of breast cancer, the following may therefore be used without restrictions: a copper IUD, Mirena coil, the etonogestrel only implant Nexplanon, the depomedroxyprogesterone acetate, depo-provera can be used, the POPs can be used. Combined hormonal contraception, inform women aged over 35 with a family history of breast cancer that there's an increased risk of breast cancer associated with taking the oral contraceptive pill, given that the absolute risk increases with age. Advice to women up to age of 35 with a family history of breast cancer should be in keeping with general health on the use of oral contraceptive pill. So this is actually a really good, nice guideline explaining some of these things. Makes a lot of sense. Now let's move on to, I just want us to look at these hemochromatosis. Hemochromatosis, hereditary hemochromatosis is inherited as an autosomal recessive condition. So this is on the NHS leaflets. So I just went on to look at this. So causes of hemochromatosis. Hemochromatosis is caused by a faulty gene. So mutation is described as a faulty gene mutation. It affects how the body absorbs iron from your diet. You are at increased risk of developing this condition if both of your parents have their faulty gene and you inherit one copy from each of them. So because it's autosomal recessive, obviously, for you to develop the condition or the disease, you need to have inherited, you need to be homozygous. It has to be homozygous, you have to be homozygous, which means you need to have inherited the faulty gene from both parents. If you inherit the faulty gene from only one parent, you end up being a carrier. And if you don't inherit the faulty gene, you wouldn't be affected, meaning that part of the disease, not be a carrier. If you don't get hemochromatosis, if you only inherited one copy of the faulty gene, or there's a chance you could pass the faulty gene onto any child, and pass the faulty gene onto any children you have. Obviously, it's random selection. If you do inherit two copies, you will not necessarily get hemochromatosis. And that's where penetrance comes in. So you could have you could inherit two faulty genes, but the penetrance or penetration could be less in such a way that you might not have symptoms, or you have mild symptoms. Whereas someone else who inherits two genes, abnormal faulty genes, would still have more severe symptoms. So only a small number of people with two copies of this faulty gene will ever develop the condition. It's not known exactly why this is. Obviously, that's where penetrance comes in. Now, treatment of hemochromatosis. There's currently no cure for hemochromatosis, but there are treatments that can reduce the amount of iron in your body and reduce the risk of damage to your organs. Of course, hemochromatosis can affect any organ, can affect your brain, can lead to, of course, cognitive problems, can lead to heart failure from iron iron deposition in the myocardial cells. It can lead to, of course, liver cirrhosis, damage to your pancreas. There are two main treatments of hemochromatosis. One is venesection or phlebotomy, a procedure used to remove some of your blood, or it's also called bloodletting. This may need to be done every week at first and can continue to be needed 2 to 4 times a year for the rest of your life. Chelation therapy, where you take medications to reduce the amount of iron in your body. It is only used if it's not easy to regularly remove some of your blood. So the first line treatment is venesection. Obviously, some chelation medications, tablets can be used as well. You do not need to make any big changes to your diet to control your iron levels if you have increasement, but you will usually be advised to avoid breakfast cereals containing added iron supplements, vitamin C supplements, and then drinking too much alcohol. Because it's like, if you're drinking too much alcohol, it's like double hit to your liver. Because alcohol can damage your liver, and then hemochromatosis can also damage your liver. So it affects your liver in every amount of good by avoiding necessary medications, which can be toxic, and avoiding alcohol, which can be toxic as well. When to see a GP? See a GP if you have persistent or worrying symptoms that could be caused by hemochromatosis, particularly if you have a Northern European family background. If a parent or sibling has hemochromatosis, even if you do not have symptoms yourself, tests can be done to check if you are at risk of developing this problem. And what are the symptoms of hemochromatosis? Symptoms of hemochromatosis usually start between the ages of 30 and 60. Common symptoms can be fatigue, feeling very tired, weight loss, weakness, joint pain, and ability to get or maintain an erection. Irregular periods of stopped or missed periods, brain fog, mood swing, depression, anxiety. Now, hemochromatosis is an inherited condition where iron levels in the body slowly build up over many years. This build up, known as iron overload, can cause unpleasant symptoms. So actually what causes is that there's excessive absorption of iron, unregulated excessive absorption of iron from the gut. It's good to know that, and it's also good to be able to explain the autosomal recessive inheritance, which means you need the 2 faulty genes for you to actually, and even if you have the 2 faulty genes, it's not a guarantee that you must have the disease. You could still not have a disease, or you could have mild symptoms, or you have severe. It's difficult to know exactly how a person would manifest or present. Let's look at alcohol. Management of alcohol withdrawal. Let's see if anything about alcohol. So if, for instance, how do you screen for alcohol dependence? So we have the SADQ, severity of alcohol dependence. That one is severity. How do you generally screen for alcohol dependence? So the audit sees alcohol use disorder identification. So you want to identify whether the patient is dependent on alcohol or not, or abusing alcohol. So alcohol use disorders identification test audits. It's a comprehensive 10-question alcohol screening tool. It was developed by the WHO and World Modified for use in the UK and be used in a variety of health. So common questions to ask is, how often do you drink? How often do you have drinks containing alcohol? How many units of alcohol do you drink on a typical day when you're drinking? How many units you drink? How often have you had 6 or more units? If you're female, 8 or more units, you're male on a single occasion in the last year. How often during the last year have you found that you were not able to stop drinking once you started? Very important questions. You continue SC, screen alcohols, how much alcohol, how often do you drink alcohol? Obviously, when you drink, how much do you drink? Have you ever lost consciousness from drinking? Have you ever been, intoxicated? Have you ever been admitted because of alcohol? You're trying to gauge how bad this person's alcoholism is, and obviously you need to be checking for withdrawal symptoms. What happens if you ever try to cutting down your alcohol? What happens when you stay maybe like 12 hours, 24 hours without alcohol? What happens? You notice any changes in your body? withdrawal kind of symptoms, you know, what are your thoughts about cutting down on your alcohol? Let the patient explain. Say, oh, yeah, I've thought about it. Have you tried before? You know, so you mustn't ask all these questions. It's all about being for the SCA and all most medical clinical exams. It's about being reasonable. You need to see that you're thinking in a rational, reasonable way. How often during the last year have you been able to do what was normally expected from you because of drinking? So things like, you know, how is alcohol impacting on your life? You know, and then let the patient explain. So, like, what do you do? Do you work? Do you think alcohol could be having any impacts on work? You know, is it having any impacts on your relationship and things like that? How often during the last year have you needed an alcoholic drink in the morning to get yourself going after a heavy drinking session, so hangover and all that? How often during the last year have you had a feeling of guilt or remorse after drinking? How often during the last year have you been unable to remember what happened in life because you drank so much? Have you or someone else been injured as a result of drinking? Have you ever been admitted? Have you ever sustained any injuries which could be related to your drinking? So most patients, a lot of the time, patients don't really like questionnaires. Patients like open questions that give them the opportunity to express themselves. It's about knowing what you should be asking and not necessarily using a formal questionnaire all the time. So now let's assume you've identified that this patient has a problem with alcohol. So you've identified using the audit and you want to know the severity of this problem they have. That's where the SADQ, severity of alcohol dependence questionnaire, the SADQ comes in. So the questions in the SADQ now are things like the day after drinking alcohol, I woke up feeling sweaty. So never, almost never, nearly always. So what happens? So if you have, first assume you have a drink today, or what happens? How do you feel the following day after you've had a drink? So the patient tells you, well, I felt well. The patient, oh, I feel so dreadful. I felt like really felt really shaky, they're having withdrawal symptoms, felt very agitated, felt sick. So the day after drinking, my hands shook first in the morning. So having tremors, agitation. The day after drinking alcohol, my whole body was shaking violently first in the morning. It helps you gauge, are they having withdrawal symptoms? If yes, what's the severity of the withdrawal symptoms they're having? The day after drinking, I woke up absolutely drenched in sweat. The day after drinking, I dread waking up in the morning. The day after drinking, I was frightened to meet people first in the morning. The day after drinking, I felt at the edge of despair. When I woke the day after drinking, I felt very frightened. Agitation, depression, tremors, and all of that. The day after drinking, I like to have an alcoholic drink in the morning and over effects. The day after drinking alcohol, I always gulped my first few alcoholic drink down as quickly as possible. It shows addiction, like the patient is becoming dependent or addicted to it, such that once you see in addiction, there's a craving, such that the moment you see that particular drug or substance, you just rush it. The day after drinking alcohol, I drank more alcohol to get rid of the shakes. So not using more alcohol to cure the withdrawal symptoms. The day after drinking alcohol, I had a very strong craving for a drink, and I would say this SADQ is exploring you identify this person has an alcohol in the audit, and then use the SADQ to check for withdrawal and severity of withdrawal symptoms. Because in the SCA exam, SCA, you wouldn't really have time to do all these in detail, but as long as you're asking reasonable, brief questions that helping you make a reasonable diagnosis and come up with a formulate a management plan which you share with the patient. I think that's what really we want to see, being logical, being reasonable. Let's go to NICE guideline, NICE CKS. What the NICE CKS, let's look at the gender dysphoria. This gender dysphoria in the NICE central base. Okay. Really? Domestic abuse. So how do you manage domestic abuse and stuff like that? The NICE CKS. So how should I assess a person experiencing possible domestic abuse? So in the SCA, it's possible to have a case where someone comes in looking down and not really talking much, or she has a bruise on her face, she's just looking downcast, I mean? Mm, Both male and female is advisable that you need to be checking, asking, this stereotype, asking domestic abuse towards female patients and ignoring that question when it comes to male patients. It's always good to ask for history of domestic abuse in men as well, because it happens, so it's really good. And the SCA, I wouldn't be surprised if they bring that kind of scenario where if a man who's actually been a victim of domestic abuse and you need to explore and extract that information. So all health care staff should be trained to recognize possible signs of domestic abuse at an early stage to inquire sensitively and safely. So very sensitively. So I can see you look really sad. What's going on? You don't look happy. I can see you look downcast. What's really going on? Do you want us to have a chat? I'm happy you're here because I sense something is going on and it's really troubling you. And I think I believe this is a really safe space for us to talk. If you're happy for us to talk, then pause and give that person the space. First thing the person wants to say that you're acknowledging that they're not happy, they're looking sad, something is really troubling them, and then obviously telling them that you're happy they've come in, but this is a safe space and you're happy to have a chat with them, to find out how we can help. Usually, once you reassure the patient, offer confidentiality, offer that safe space, the person usually feel like, yes, this doctor is a reasonable, sensitive, and sensible person. Know how to respond to a disclosure. If a person presents with indications of possible domestic abuse, allow the person to make a disclosure alone in private with no third party present. Ensure that the person feels safe, is given time and space to talk. And questions are asked in a kind, sensitive manner. Because listen closely with empathy, judgment. You don't need to be judgmental, you need to listen empathetically, listen actively, show that you care, things, making those emoji sounds like, right, okay, oh dear. So how have you been coping? I'm really happy you've come here today. I'm really happy you've come here today. I believe we'll be able to help and support you. Use gender neutral terms such as partner or ex-partner. Instead of saying wife or husband, you can say partner. Ask the patient for safe contact details. If you want to be contacting the patient, have you got a number, have you got a phone that you don't, that's very private to you, so I can always reach you. Ask about where the perpetrator where the perpetrator is, if there are any children, in the picture, if they have access to children. Ask about who they are frightened of and who they are frightened for. Ask what they would like to happen. Use a professional interpreter or an advocate from a local specialist domestic violence and abuse service. So, professional interpreter, for instance, if it's a language barrier, not use the person's child relative as an interpreter. Because it's very common, because the UK is becoming more and more and more culturally diverse, so it's very common to have patients that actually don't understand English. They speak Arabic or they speak Greek, they speak Spanish, Portuguese, and they might not be able to understand English. So, it's good to have a non-biased and independent interpreter in language line. Advise the person that any discussion is confidential and the information provided will be shared only with the consent, subject to practice policy on around child safeguarding. If it is believed that withholding information puts a child or another adult at risk of significant harm, then disclosure may be justified in the public interest and or in order to protect the vital interests of the third party. Ask open or direct questions about domestic abuse. Consider asking open questions such as how are things at home? Sometimes symptoms can be triggered by stressful events in a relationship. Has anything like that happened to you? We know violence at home can be a problem. Is there anyone who is hurting you? So asking it in a non-judgmental, non-personal way, like we know violence at home can be a problem. Is there anyone who is hurting you? Consider asking direct questions such as, do you feel safe at home? Does anyone make you feel afraid? Do you feel safe in a relationship? Is there anything that worries you about your relationship? These injuries are more than I would expect following a fall. I'm wondering if something else may have hurt you. Try and establish the range of abuse. If the abuse is getting worse or happening more often, or the incidents themselves are getting more serious, good to establish that. So just the person keeps a diary of incidents or threats when and where they happen, if anyone else was with them, and if they were fighting. Try and establish if the abuse is affecting other people in the household, elsewhere, such as children, siblings, or anything. Ask about emotional abuse, physical abuse, social, practical needs, and concerns. Consider asking specific questions relating to different forms of domestic abuse, depending on your clinical judgment. So things like, for emotional and psychological abuse, does your partner or former partner repeatedly belittle you? They put you down? Do they say you're worthless? Do they blame you for the abuse, arguments? Do they deny that the abuse is happening and play it down? Do they isolate you from your family and friends? Do they stop you from going to work? Do they make unreasonable demands of your attention? Pay attention? Do they accuse you of flirting, having affairs? Do they tell you what to wear? So they controlling, do they control your finances, where you go, who you hang out with? Do they threaten you, they intimidate you, they controlling any physical abuse, any sexual abuse? Is your partner, ex-partner ever touch you in a way you don't want to be touched? Do they make unwanted sexual contacts or demands? They hurt you during sex, including non-fatal strangulation. Hmm. Do they pressure or trick you to have unsafe sex? For example, deception over the use of contraception like condoms. Do they intentionally expose you to STIs, to threatening to you? So there is a lot you can never go. It's just a lot. It's endless on ways to sensitively get information on domestic abuse. Talking to a child about possible domestic abuse, talk sensitively and ask simple and direct questions to allow opportunities. Obviously, very careful. It's something that you need to be very careful with when you're discussing with a child because on legal reasons, you need to, you say, do not interrogate the child, do not ask leading questions, especially if to very, do not ask questions that will be classified as you led the child down a rat hole, you box them into a corner. Preferably if you're going to explore that, you need someone else, you need a third party, not a colleague of yours or a nurse who will be there, so that you guys can explore these concerns. If the person is unwilling or unable to disclose domestic abuse at this time, assess whether the person is at immediate risk of harm, offer follow-up and convince your care possible advisor that you are available to talk if and when they are ready. Be aware of possible reasons for non-disclosure, such as fear from the perpetrator, fear of retribution, pressure from family or community, fear of causing the family breakdown, shame or embarrassment, not identifying their experience as abuse. Very important. That goes to, of course, you have to offer confidentiality to those patients. And then what are the available supports? You need to be, making this patient aware that there are several available services that are there to support them. So obviously they think they have immediate risk, of danger, then we can be calling it inspiring the 999 at the National Domestic Abuse Helpline. We have some Samaritans, we have victim support. There's women's aid, there's men's aid, there's mankind for men, for male victims of domestic support, mankind initiative, respect, helps both men and women. Survivors UK, Women's Aid, Childline, Children Gallop. So Gallop is a charity for members of the LGBT community who are experiencing domestic abuse or domestic violence. So, also needs to be letting them know that you want to speak with a safeguarding lead or the practice to get more guidance on what should be done, encouraging them to keep sensitive documents, in case they have to perform an emergency, escape, then they need to keep their documents and important stuff, things that are important to them in one place, you can easily grab them. They need to escape from, immediate danger. obviously, if it's a domestic abuse, they can always check and consider consider spousal counseling, marriage counseling. Advise the person that any discussion is confidential and the information provided will be shared only with the consent subject to practice policy on adult and child safeguarding. There's a risk of significant harm to a person or other adult sharing information with other agencies and services appropriately. Very important. These are very important information. Let me see. This sterilization. Any information on sterilization? In terms of vasectomy. Vasectomy. See, that's an information. Vasectomy. There's nothing there. Vasectomy. Let's look at failure rates of vasectomy. For failure rates, if you imagine a patient coming there saying they want vasectomy, it could be that a patient wants a vasectomy and they don't want the spouse to know, so it's a vasectomy. You want to check if the patient has discussed it with their partner, and what was the opinion of the partner in agreement. Because the patient wants vasectomy, even if the partner doesn't want, can still go ahead because the patient body, we need to explore why, what are the concerns, why don't want to tell the partner, what do they know about vasectomy, and you have to tell them about failure, that's no form of contraception, even though they describe it as a permanent form of contraception, there's a chance of reversibility, even though the likelihood of success for many attempted reversibility is usually small. I think to tell them that it's a very reliable form of contraception, but it's not 100% effective, which means that there could be a failure rate of 1 in 2,000 after the negative semen analysis. Because normally you need a negative semen analysis. We need to tell them that there can still be some failure from that. So let's look at reversibility. So vasectomy is reversible in 50% of cases. Success is less likely when more than 2 centimeters of vas or the convoluted part is removed. Since reversal cannot be guaranteed, it's essential that the patient is adequately counseled with stress placed on factors such as the effects of possible loss of a child and the long-term stability of patient's condition. So there's you need to find out, have they thought about the likelihood and do they think there's a chance they might regret the decision in the future? How many children do they have? Walk your way through that. Complications of vasectomy. There's no evidence that vasectomy results in an increased risk of cardiovascular disease, prostatic or testicular cancer, erectile failure, or autonomic or autoimmune disease. There's no evidence linking osteoporosis development and breakdown vasectomy. Early complications following vasectomy occur in 1 to 6% of men. Early complications like hematoma, wound infection, cyst-like sperm granulomas, epididymocarditis, and congestive non-infective epididymitis. The most common side effects are wound hematoma, staphylococcal wound infection. Most men will develop wound hematoma to a but large problematic hematoma formation is rare. Development of post-operative hematoma may be limited by adequate scrotal support. So post-vasectomy adequate scrotal support, avoidance of physical exercise for 3 to 4 days. Following the procedure. Now, late complications following vasectomy. Chronic testicular pain has been found to be the most common late complication. Men should be informed of this possibility so they can have chronic testicular pain following vasectomy. Significant chronic orcalgia may occur in up to 15% of men. Oncologists, I've never really heard that they're oncologists, but if it's significant chronic oncology, I can occur in 15% of men. So you've seen the failure rates, which is 1 in 2,000. Yeah, I'm seeing that just reversibility can be reversible in 50%, which means there'll be failed reversibility at 10 to 50% as well. What that means. Look at female sterilization. Female sterilization to ligation. Female sterilization. Female sterilization. Let's look at some information there. So failure rates for female sterilization, I think is how many is it? 1 in. So fuchsia clips are the most commonly used method of female sterilization in the UK, which means you're not really cutting fuchsia clip, you're not really cutting the fallopian tubes, you're clipping them. The aim of the clip is that the clip is going to crush that segment of the fallopian tube and it will end up healing by fibrosis and blocking the lumen of the fallopian tube at that point. So sterilization via these fuchsia clips fails in about 2 to 3 per 1,000 cases. So we've seen that the vasectomy failure rate is 1 in 2,000, isn't it? 1 in 2,000 means 1 in 2,000 means 0.5 in 1,000, which means it has a higher success rate than female sterilization. Yeah. So 2 to 3 per 1,000, 2 years, with a lifetime failure rate of 5 per 1,000. These are generally less successful than rings or the Pomeroy procedure. Often, this is due to the failure to detect an early implantation at the time of operation. Steps may be taken to reduce this. So, which means early implantation, the person might already have been pregnant. Is that what it means? Before applying the fuchsia clip. That's reversibility of female sterilization. So reversal of sterilization is requested in more than 1% of previously sterilized women, and in nearly 5% of those who made their original decision immediately after delivery. When a lady is counseled regarding reversibility of the procedure, she should be told that she should consider the procedure irreversible. The actual success of reversing the procedure is dependent upon the sterilization technique that was previously used. It's easier when rings or clips were used than when there was an actual tubal incision and ligation. The length of the tube destroyed. So if you had a longer segment of the fallopian tubes destroyed, then obviously the chance of reversibility is slim. Whether or not the fimbriae are involved, then the chance of fertilization, the chance of pregnancy essentially is far less. The proficiency of the surgeon doing it. With modern microsurgical techniques and a good surgeon, a subsequent pregnancy may be expected in up to 70% of cases. Well, that's quite impressive, obviously. You have micro surgical anastomosis of the fallopian tube ends, and obviously there can still be a chance of reversibility. But so also tell the patient, even if there is a chance of reversibility, even if it's reversible, there's still a higher chance of that pregnancy being an ectopic pregnancy if she gets pregnant. There could still be some from fibrous tissue and some narrowing on the fallopian tube at that point. Side effects of female sterilization. The side effects of sterilization are primarily those of the surgical procedure, risk of anesthesia, possible infection, possible bowel damage. There's an increased risk of ectopic pregnancy should the procedure fail, because even if you try to reverse it, there'll still be an increased risk that the pregnancy could be ectopic. So counseling for female genital sterilization, ideally both partners should be seen together. But it's not necessary to obtain a spouse's consent, because the same thing goes for male sterilization. You advise them, because as a doctor, obviously you want the best for the patient. And part of the best for the patient is that you want them to have a happy and supportive spouse, or family. So you want to check what their spouse or their partner, thinks about this big, huge decision that they're about to make. Important points to discuss may be remembered by the new one, theme 5. The failure rates mandatory to explain that the results cannot be guaranteed, obviously. The procedure should be presented as being basically irreversible. They explain this. They should see it as an irreversible procedure, and she stressed, however, if she ever changes her mind, there's a chance that if properly done, depending on how it's done, there might still be a chance of this procedure being reversed. But the other thing that even after reversal, still slightly increased chance that and she gets pregnant, pregnancy could be outside the womb, which is called an ectopic pregnancy, which usually can be a serious condition. You need to explain all of that. You may say, what do you think? What are your thoughts about everything I've said? Laparoscopy and laparotomy are the methods most commonly employed. So it could be done through a keyhole and open surgery. Figures may be initially heavier following laparoscopic sterilization. Vasectomy is a desirable alternative, particularly if it is simpler, particularly if it is a simpler procedure with fewer complications. They need to share aware of vasectomy, then there can also be a male sterilization. That's what women like that alternative. So they might say, oh yeah, my husband should do it, my partner should do it. Yeah. Advice following laparoscopic sterilization. So this depends on the form of contraception used before the procedure. Women should be advised to use contraception for at least up to the day of operation. If methods of contraception are used, so the whole thing is that you want to make sure that you're not doing a sterilization on a woman who's already pregnant. If methods of contraception are used, which do not prevent ovulation, such as IUCD, then contraception should be employed until menstruation occurs, because there may be an ovum already within the uterus. The patient should be informed of the possible side effects of the procedure. Now, for vasectomy, let's go back to vasectomy. Yeah, something like let's go back to vasectomy. So let's really have this little, let's read this short notes on vasectomy. So vasectomy is a surgical procedure used to produce male sterilization. It's a relatively simple procedure performed under local anesthetics and associated with minimal mobility. The vas deferens is identified at the top of the scrotum by palpation and separated from adjacent blood vessels. You need to separate it from adjacent blood vessels. If you don't want to nip the testicular artery and cause testicular atrophy, you don't want that patient will not forgive you. But all of the vas deferens is then excised. The patient must be warned that sterility is not immediate, and that other forms of contraception should be employed until the ejaculate is confirmed to be sperm-free. So you need 2 negative seminal fluid analysis starting 3 months after the operation. So he was from the point where he's had his vasectomy 3 months later, we'll do seminal fluid analysis to check if sperm cells are still present. And even if the sperm cells have been not found, he needs to have a second seminal fluid analysis a month later. So starting at 3 months of and taking 1 month apart, recommended before certifying that the patient is sterile. With these precautions, less than 1 in 1,000 sterilizations fail. It is usually the result of the recanalization of the vas. If you've cut the vas, how does it get recanalized? Right, magically, it's how the 2 ends. So it depends on the amount of vas, obviously, the length of the vas that is taken off. However, DNA qualified fatherhood has occurred in the absence of clinically detected spermatozoa within semen. DNA qualified or DNA confirmed fatherhood has occurred in the absence of clinically detected spermatozoa within semen. How is that possible? Wow, it's magic. Okay, is there another thing we want to look at? Let's see. Let's look at opioid. Opioid conversion. Management of opioid dependence. Let's look at management of opioid dependence. So management of opioid dependence, or essentially opioid substitution therapy. So opioid substitution therapy, we're looking at medications like sublingual buprenorphine. Buprenorphine is a partial opioid receptor agonist. So sublingual buprenorphine can be used. Buprenorphine oral lyophilase, which is a lyophilate, is something that you put in your mouth and just dissolves, it can be used oral mucosal administration, like a buccal, it's like a buccal buprenorphine. So methadone is usually liquid, so methadone oral solution, 1 milligram per meal. In opioid dependency, initially you're giving them maybe like 10 mils, 10 to 30 mils, which is 10 to 30 milligrams, usually liquid. That's like where they use oral morphine, they just put it in a syringe and take that in a cup, small cup, 10 mils, 30 mils. Increase in steps of 5 to 10 milligrams daily if pregnant, until no signs of opioid withdrawal or no evidence of intoxication. The dose should be increased in the first week, then increase every few days as necessary. So the most important thing is that you need to tell this patient, yes, there are medications that can help you, just with the drug and alcohol service, you need to be advising the patients to prepare themselves to the drug and alcohol service. In Devon, we have together. We have together drug and alcohol service, so you need to be advising patients to self-refer. It's usually better for them to self-refer, because that way, if they self-refer, they are more motivated to engage than if you do the referral for them. And then you are advising that there are medications that can help them, not develop opioid withdrawal symptoms like methadone, naltrexone. So naltrexone can be used for buprenorphine. So naltrexone can also be used for alcohol withdrawal, alcohol sedation as well. Naltrexone can be used for that as well. So you can see naloxone is not used in opioid substitution therapy. Naloxone is used in acute opioid withdrawal, but it's not used in the management of opioid cessation or management of opioid dependence when you're trying to stop someone from being dependent on an opioid, which is a gradual process usually. Lofexidine obviously should be prescribed by the drug and alcohol specialist team. Drug and alcohol specialist team. Let's have a read through this one as well. So management of opioid dependence, methadone and buprenorphine. For the management of opioid dependence, so methadone and buprenorphine, oral formulations, using flexible dosing regimens are recommended as options for maintenance therapy in the management of opioid dependence. The decision about which medication to use should be made on a case-by-case basis, taking into account a number of factors, including the person's history of opioid dependence, their commitment to a particular long-term management strategy, and an estimate of the risks and benefits of each treatment made by the responsible clinician in consultation with the person. If both medications are equally suitable, methadone should be prescribed as the first choice. Methadone is usually preferred. Methadone and buprenorphine should be administered daily under supervision for at least the first 3 months. Supervision should be relaxed only when the patient's compliance is assured. Both medications should be given as part of the program of supportive care. Methadone and buprenorphine can be abused. So even though they are used in opioid substitution to treat some patients who have opioid dependence, in themselves, they are opioids and they can become drugs of abuse. So that's why it has to be supervised until you got to the point where you're satisfied that this patient is unlikely to abuse them. This patient has got to the point of what I will call the point of freedom. They now have the ability to control that's no longer having the craving, and they've now got to the point of safety. You can ask, okay, you know what, we can now trust that these patients can take decisions on their own. We can now trust that this patient has developed the self-will and the ability to resist any urges to engage in drug abuse or dependence. Evidence shows methadone is more effective than buprenorphine at retaining people in treatment and reducing heroin use. Heroin is a very strong opiate. Drug interactions can slow down or speed up methadone metabolism or can potentiate toxicity. Prescribers should consult the BNF when prescribing medications for patients for already on methadone. Patients with any risk factors for QT prolongation should be carefully monitored while taking methadone, including but not limited to heart disease, liver disease, electrolyte abnormalities, or concomitant treatment with medications that can prolong the QT level. Patients requiring more than 100 milligrams of methadone daily should be monitored. Clinicians, either at initial assessment or prior to induction, can consider use of ECG where they have concerns. Clinicians should be acting according to local protocols, the local policy, and the orange book. So very important to be able to have this conversation with the patients who say, doctor, I actually use heroin. And I've tried to stop, but I'm just not able to stop. Each time I try to stop taking the heroin, I feel very unwell. And there are ways I can be supported to stop to stop using heroin, for instance. And then you need to go through this, you need to be advising, thanking them for coming in. I'm really happy you've made this decision to come into the house to have this chat. And I'm even more happy that you've made the decision to really consider stopping, the use of heroin. So make them realize that you're actually pleased that they want to take that bold decision. It's a really bold step. I'm happy to say that there are so many there's so many ways we can support you, through this phase. Find out why they made that decision. Just checking, just really checking. Why have you made a decision today? What has led you to this point of making this huge decision, this very clear decision? And allow them to speak. There's something I want us to look at as well again. Yeah, let's look at there's something below this one. Medications that are used in weight management. And I'm just imagining another possible SCA scenario would be that the patient has come to you because they're just feeling embarrassed about their body weight, their body image, and they really want to be supported in terms of losing weight. Again, you have to thank them for coming, what has led them to making these decisions. Is something they've tried before, have they tried to lose weight before, what measures have they currently thought about? Is there anything they're trying at the moment, find out how that is going, are they struggling with that? You might tell you that, you might consider whether you need to do some blood tests to check, make sure she's not hypothyroid, for instance, she be having Cushing's syndrome, she have polycystic ovary syndrome, female patients, you need to be checking, thinking, broadly. Then, is she particularly concerned about anything? Obviously, she's gone for her weight, but anything she might say, she knows that being obese or being overweight can increase the risk of breast cancer. And her mom has just been diagnosed with breast cancer, for instance. You know what I mean? So you need to find out why. Particularly worried about her weight. Question you ask yourself, why now? Is there something that's happened recently? So in terms of, obviously, you have to be talking about diet, exercise, cutting down on alcohol, smoking cessation, generally healthy lifestyles. And obviously there are medications that help. The common one is Orlistat. And then there's some semaglutide, which is a GLP-1 analog. That can also be used as a semaglutide injection. It can be used, it comes with a pre-filled 10 milligram in 1 meal. Typically, if it's diabetes, for diabetes, you typically start at 0.25 milligram, and then you can increase to 0.5, and then you can increase to 1 milligram once a week. Not particularly short in dosing semaglutide. That's This one is set melanotide, no, GLP-1 analog, that's semaglutide, yes. Yeah, semaglutide, that's the one. Wegovy, okay. So Olistat is usually given 3 times a day, 120 milligram capsule 3 times a day with meals. I think they usually say if you avoid, if you skip a meal, you can skip the Olistat actually. Olistat should only be prescribed with adults who meet one of the following criteria: BMI of 30 or more, which means obese, a BMI of 28 or more with associated risk factors. Continuation of therapy beyond 12 weeks, which is beyond 3 months, should continue only if the patient has lost at least 5% of their initial body weight from the start of the medication therapy. Healthcare professionals will need to decide whether the anticipated weight loss, generally 5%, is of clinical significance to the patient. If prescribed, the patient should be counseled on the adverse effect profile of Olistat, particularly in connection with gastrointestinal because of flatulence. Flatulence, it's a common, because what it essentially does is it will create a fat malabsorption. So reduce how much fat your bowels, your intestines are absorbing. So you have symptoms similar to fat malabsorption, flatulence, sticky, pasty kind of stool and all. Olistat 60 milligrams are now available. So typically in an adult, I think it's 120 milligrams 3 times a day. That's the usual dose. And it's a lipase inhibitor. So lipase obviously is for the pancreatic enzyme that's involved in the breakdown of fats and obviously the absorption of breakdown fat into fatty acids that then absorbed. So if it inhibits lipase, then you're not able to break down your fat in your diet, so fatty acids, and the fatty acids are not being absorbed. And then obviously the fatty of fats is going out in your stool, so you have steatorrhea, which is fatty, pasty kind of stool, and lots of flatulence. This melanocortin 4 receptor antagonists should be prescribed only by the specialist, same as GLP-1, the glucagon peptide 1 receptor agonists, like the semaglutide. Usually they should be prescribed only by the specialist. So semaglutide can be used as an adjunct. So a reduced calorie diet and increased physical activity for weight management, including weight loss and weight maintenance in adults who meet the criteria in mice. So Wegovy, which is semaglutide, is not yet commercially available, prescribed by a brand to aid identification where products contain multiple ingredients, or to prevent confusion where multiple brands contain similar ingredients or have different license indications. Wegovy is licensed for weight management. Ozempic and Ribesi are licensed for treatment of type 2 diabetes and should not be prescribed for weight management. So you can say Ozempic is semaglutide, Wegovy is semaglutide, but they're advising us to prescribe Wegovy brand for weight management, but it should be started by at the weight management clinic. When you do a tier 3, you refer to tier 3 in weight management services. Semaglutide Wegovy is recommended as an option for weight management. Wegovy, weight, sounds like weight is not Wegovy. Okay. Including weight loss and weight maintenance alongside a reduced calorie diet and increased physical activity in adults, only if it is used for a maximum of 2 years and within a specialist weight management service, providing multidisciplinary management of overweight or obese, of overweight or obesity, including but not limited to tiers 3 and 4. If the patient has at least one weight-related comorbidity, which could be severe knee or severe hip, posterior ankle, osteoarthritis, the person having breast cancer can be linked to being massively obese, persons having COPD or having obesity, hypoventilation syndrome, things like that. Or even heart failure, you might want to be encouraging them to, the patient having heart failure and having morbidly obese, and the person just can't, the exercise tolerance is just so poor, we need to be using medications to aid weight reduction. If the patient has at least one weight-related comorbidity and a BMI of at least 35, so morbidly obese, or BMI of 30 to 34, and meets criteria for referral to specialist weight management service. If if you use lower BMI threshold, usually reduced by 2.5 for people from South Asian. Use lower BMI thresholds. I'm not sure why. And people from this place has particularly increased risk of cardiovascular events. Again, when it comes to people from certain parts of the world in terms of predisposition to certain diseases, cardiovascular risk, it still boils down to the fact that most people marry within their race. So there's a 40 gene within, for instance, if one white man has a 40 gene and marries a white lady, there's a chance that that 40 gene continue. If one Indian man marries an Indian lady, and one of them has a 40 gene, then that 40 gene more likely, then maybe their children will be Indian children will likely marry Indian. So obviously people with interracial, the more we have interracial marriages, the more most of all these things gets diluted out. Consider stopping semaglutide if less than 5% of the initial body weight has been lost after 6 months of treatment. So if less than 5%, so you're like, the bottom line in weight management medications, the person hasn't really actually lost 5% of their body weight loss in 3 months, isn't it? You want to go back to Orlistat. Yeah, so if they haven't lost up to 5% of their body weight in 3 months, you're like, maybe this medication is not actually doing what it should be doing, and you might need to stop it. But that's for 3 months for Orlistat. They're saying for semaglutide, if they haven't lost up to 5% of their initial body weight in 6 months, so it's semaglutide, you give it a longer period of time, which is good to know. No dose adjustment is needed in elderly patients, in hepatic impairments, or those with mild or moderate severe renal impairments. Semaglutide is not recommended for people in patients for use in patients with end-stage renal disease. For use of semaglutide or Ozempic, this one is diabetes. So people to know, patients in SCA, for instance, patient might say, oh, doctor, I just heard my friend is using a medication, an injection for weight loss, and I just really want it. It's so brilliant. You're like, okay, yeah, okay. Can you tell me more about this medication? What do you know about this medication? Oh, the medication is maybe Equivir. I won't say Ozempic. But, Orlistat. Orlistat is called a diet tablets. No, that's what patients commonly call it. The diet or weight loss tablets. Orlistat. There's anything below that we need to be thinking about. Postnatal depression. Okay. Yeah, I think we should take a break. We've done well. Cheers, guys. Take a break.